Good evening, everyone, and thank you for your patience as we get started with tonight's presentation, the title of which is How Culture Affects Your Risk of Heart Disease. And thank you for making an effort and joining us and making your health a priority by spending this next hour with us. I'm your host, Jenny Hawk. I'm Senior Marketing Specialist for Franciscan Health. Our cardiologist has some great information to share with you this evening. And by the end of our time together, you will know more about what researchers are finding out when looking at a person's cultural and ethnic background and how it influences their risk for heart disease, particularly those of South Asian background, which populations are especially affected by this higher risk of heart disease, and what you can do today and tomorrow to lower your risk of heart disease and to contribute to better outcomes should you need care or surgery. And before we get started, we have a few housekeeping items. For this virtual event, participants are muted. We ask that you remain muted to help us avoid background noise and interruptions. And if you have questions to ask our presenters, please type them in the chat window or the Q&A window. I will be answering your questions at the end of the webinar as we have time. Our administrator, Kirsten Wachowski, is taking care of everything on the back end this evening. So if you experience any technical issues, just type them into the chat window and we'll work to resolve them as quickly as possible. And if you miss anything, don't worry, or in taking notes, we'll send the recording of tonight's presentation to you in a follow-up email. And so let's get started. First, we'd like to know a little bit about our participants. Right now, we have 14 people listening tonight, and we have several more that probably will be joining us later. For our first poll question, though, please choose the answer that best describes why you're interested in this topic. Number one, I'm concerned about my family history of heart disease and want to learn more about improving my heart health. Number two, I want to make sure my family and I know what puts us at risk of heart disease, including our cultural background. Or number three, I want to learn heart health basics, including diet, weight, and physical activity, and other measures I can take. Now, more than one may apply to you, but we realize, but just choose one for now to start the discussion. All right, 50% of you chose C. I want to learn heart health basics, including diet, weight, and physical activity and other measures I can take. Well, now I'm very pleased to announce our presenter tonight. He is a board-certified cardiologist in our Franciscan Physician Network. He joined us in 2022. Dr. Ankur Kalra was educated at Indira Gandhi Medical College and completed medical and cardiology training at the All India Institute of Medical Sciences, Cooper University Hospital in New Jersey, Hennepin County Medical Center, and Minneapolis Heart Institute in Minnesota. He served as a clinical and research fellow in interventional cardiology at Beth Israel Deaconess in Massachusetts and was a clinical fellow in medicine at Harvard Medical School. He completed a year-long fellowship in advanced interventional and structural cardiology at Houston Methodist DeBakey Heart and Vascular Center. Today, in addition to seeing patients, he is primary investigator at Indiana University's Krannert Cardiovascular Research Center. He also is an adjunct clinical associate professor of medicine at the university's School of Medicine. And somewhere between the research trials, teaching and treating patients, he finds time to be an entrepreneur, launching a nonprofit devoted to raising awareness about health issues, which he will tell you more about at the end of the program. Dr. Kalra, welcome, and thank you for bringing this current topic to our attention. Kirsten and I will turn the program over to you now.
All right, thank you, Jennifer and Kristen, and appreciate the opportunity to be able to do this for the audience. And for the audience who've tuned in, thank you for tuning in. It's late in the evening on a weekday, so I appreciate you tuning in um, to learn more about your risk, your family's risk, and also um, to understand how to better optimize that risk by improving diet and physical activity and other risk factors which put us at an increased risk for heart disease. So I'm going to dive right in. It's known, at least well known in our world, as cardiologists, that heart disease is the number one killer in men and women. That is true um, in the United States. That is true globally as well. So internationally, that fact is true wherever you go. Including parts of now we call them the less industrialized versus the more industrialized worlds. Where heart disease has become the number one killer globally. Next slide, please. So this is a map, a world map, as you can see, which was published in 2020. It was published in one of the leading journals in cardiovascular medicine called JACC, and which stands for Journal of the American College of Cardiology. And what this map is showing you is it's color coded, and if you look at your bottom left, you'll see the the legend to the color schema as to what that means or what that refers to, and it is showing you a percent change in the population which is at risk for heart disease. So the greatest at-risk population with more than 15% change, or anywhere between 0% to 15% change, you'll see is certainly there are pockets in the United States. Actually, if you were to zoom in on that map, you would see that Indiana and Ohio are um, in that color schema of maroon or brown or red, however you want to call that color. And then you'll see pockets of South Asia, certainly pockets of India, pockets of Africa, and then South America. So I think these globally, if you look at the burden of heart disease, then um, it's certainly the way we are leading and living our lives, has heightened our risk of developing heart disease during our lifetime. Now, another startling statistic here is that South Asians comprise 25% of the humankind. So if you look at the global population, the overall population, 25% of that population, so 25% of however many billion we are on this planet, South Asians comprise 2 billion. If you include, people living in India as well as people living elsewhere. So we call it South Asia. So South Asians in South Asia and the South Asian diaspora. So that's why this topic now becomes of public health importance as to why it's important to discuss the heightened risk and the risk factors. All right, next slide, please. Now, I think I sort of broadly mentioned this during my last slide, but if you look at this slide, then these are numbers within the US. So within the mainland United States of America, South Asians are now one of the fastest growing minority groups in the US. And if you look at the trajectory of growth to your right, then it is estimated that by 2060, by year 2060, population of South Asians in the United States alone is going to be 35 million. And so, it is imperative that the health needs of this minority group are critically examined for a variety of reasons. And those reasons I'm going to enumerate, although they're also listed on the slide here, is to ensure culturally appropriate medical and health services, to address a variety of serious health conditions they face, to create informed policy decisions. As I'm delivering this talk to you, we actually drafted a resolution to be considered by the Indiana State Medical Association, where we've basically impressed upon our colleagues, our physician colleagues in the state of Indiana, um, to help us raise awareness on, South Asian heart health and South Asian heart disease. And I'm going to go over some of the other statistics with you. And then to improve current and future clinical research in this group. And these are statistics and data from the Pew Research Center. Next slide, please. I think representation matters. I'm speaking, and I'm not sure many of you know, or may have known when Jennifer was kindly introducing me. And thank you for the very kind introduction, by the way, Jennifer. I am a South Asian, so I was born and bred in India, and then immigrated to the United States. I've now been living in the U.S. for the past 15 years. But if you look at South Asians in healthcare, so if you look at the healthcare workforce in particular, and if you look at South Asians, then we form the majority of the minority workforce across most domains, and roughly every second in fifth cardiologist in the United States is Asian. So if you look at nurses, for example, 7.9% are Asian. Nurse practitioners, 8.5% are Asian. Physician assistants, 10.8% are Asian. Pharmacists, about 19% are Asian. Occupational therapists, 8.6% are Asian. And physical therapists, about 14% are Asian. So in the United States, the one minority group which is forming the majority within the healthcare workforce is South Asian. So it's a matter of keeping your health providers healthy, and it is a matter of keeping your health providers at bay from heightened risk of heart disease. And that is why this topic, particularly in the United States, is crucial. It has become of crucial public health importance. All right, next slide, please. Next slide. Okay, perfect. Thank you. So unique barriers to accessing healthcare, and when I go over this slide, I'm particularly speaking of South Asian culture and South Asian ethnicity. The existing and I've sort of parsed them out into different aspects because I think it's a continuum of why there are barriers to accessing healthcare in the United States for South Asians. Maybe I think this may expand to other cultures and ethnicities as well. These barriers are cultural, they're financial, certainly health literacy, communication, and discrimination or racism. So I'm going to go over each of these one at a time. So there are existing cultural attitudes, fear and stigma of diagnosis, stigma of taking a medication, mistrust in Western medicine for a lot of people of different cultures or ethnicities. I can say that it's also unfortunately becoming more true even for the indigenous U.S. population. Financial, lack of health insurance and high out-of-pocket expense for appointments and prescriptions. Health literacy across the spectrum of cultures and ethnicities is poor. I mean, and this is despite the high rate of education. For some reason, health literacy, and what do I specifically mean when I say health literacy? What I mean by that is, just an awareness of what that diagnosis means or what the importance that a particular diagnosis carries. As physicians and as healthcare providers, we feel the health literacy is poor. And so what we do is we try to sort of communicate with our patients in a manner where what we are saying, we try to avoid medical jargon. If our communication has to involve medical jargon, we want to make sure that we are communicating it in such a fashion so that, or explaining it to our patients in such a fashion such that even a fourth grader or a fifth grader can understand what we're trying to say. Certainly there are language barriers with communication with certain ethnicities, and then many of us have experienced racism and discrimination, and so do our patients. And research has shown, and I've sort of cited the paper there, or more than actually a couple papers there, that has been associated with poor health. Next slide, please. I saw there was a poll question, so if there's a poll question, maybe we can break there and ask our audience what the answer is.
Yes. I said, what a great start to the program. Very interesting points you brought up. So for our first poll question, if everyone could choose an answer, what is the fastest growing ethnic group in the United States today? Just go ahead and choose. We just want to make sure you're listening. Very good. 75% of you said Asian Americans. And yes, that is correct. Said that the Asian American population has grown significantly since 2000. And I really enjoy what you said, Dr. Kalra, about health literacy, about we really need to understand what when as patients we get a diagnosis, we really need to understand it and understand what it means. And also that it's not only important to keep, the Asian American, population of the country well, but also those of that background in healthcare, because we definitely need all the healthcare professionals that we can to get. So yes, to keep all of those populations healthy is going to be very important.
Yes, absolutely. I think keeping your health providers healthy is crucial. Sort of, the message we learned, unfortunately, the hard way during the pandemic. But that sort of extrapolates to some of the other disease conditions, we see, and that's why, as I said, this topic is of public health importance. So the risk is heterogeneous. I certainly don't know the ethnicity of our audience this evening. But again, this is important research published in two very high impact journals within cardiovascular medicine. So Circulation, which is American Heart Association's journal, and then European Journal of Preventive Cardiology. And what this slide is impressing upon us here is that the overall risk, we know that the overall risk in South Asians is higher. That risk particularly also varies by country of origin. So for example, you'll see that. So within when we say South Asia, that usually comprises 7 countries. India, Pakistan, Sri Lanka, Nepal, the Maldives. You have you have uh, but some, if depending on what literature you read, some would include Bhutan in that category. Some would also include Southeast Asian countries. Although if you look at the World Health Organization, the World Health Organization is gonna not include, for example, the Philippines, but include the Maldives. So the definition, gets tricky. But for the most part, these are the major populations that have been studied using that definition. And you'll see that even within South Asians, there is heterogeneity as far as the risk is concerned. The risk could be as high as 4 times in Bangladeshis, and as high as 3 times in Pakistanis. If you were to compare, Bangladeshis and Pakistanis with the rest of the South Asians. So I think it's sort of important to bear that in mind when you are sort of trying to parse out these data. And then I want to impress upon the curves on the top right of the slide here, is that if you compare it with the local populations, you'll see that the tricky or the crucial age bracket is the 40 to 49 year age bracket, because that's when these curves start to separate. And I haven't really included the US here, or data from Caucasians here. But if I were to do that, you'll see that the curves separate even more, because this is some of the work we've published, I've published, and and certainly other investigators have published, which have shown that the onset of heart disease in South Asians, not only, I mean, when I say South Asians now, I'm sort of including all these countries. And you'll see heterogeneity within these countries, as you can see in these curves. But the onset starts at least a decade younger in this uh, uh, population. So Why is that important? It's important because it has a direct impact on life expectancy. It also has a direct impact on the economics of the family. So we know that I think in human life, the most financially productive years of human life are between 40 and 49. And so if someone or if a family member in that age group is getting afflicted with heart disease, that has economic consequences not only for that particular individual but also for their families. There is a term which the World Health Organization has published, which investigators have now also published in the medical literature when it comes to countries like sub-Saharan Africa or even South Asia or countries in South America, where they've coined a term called catastrophic health spending, because what is happening is that the burden of disease is severe, so it's resulting in catastrophic health spending for that particular individual or for that particular family, but it also is impacting the overall GDP of the country, because so many in that economically viable, economically productive age group are getting afflicted with heart disease. So the ramifications of this phenomenon go way beyond just the health outcomes. There are economic impacts to the families as well as to the countries when we are talking about this risk. All right, next slide. So I'm going to talk about risk factors now, and I think this gets to the area where a lot of our audience are interested. So, and these are some of the common risk factors I am putting in my clinic note when I'm seeing patients in clinic, because we know that all these risk factors independently have been associated with a heightened risk for heart disease. And when put together, they actually are synergistic. So they accelerate the progression of heart disease. So high blood pressure, the medical term for that is hypertension, diabetes, high cholesterol, family history of premature heart disease. What is premature heart disease? There is a definition for that term that we use, premature heart disease. So if in women, the first incidence of heart disease occurred when they were 55 years of age or less, that is premature onset. That age definition is different for men. It's less than 45 years. Smoking, big risk factor. Obesity, sedentary lifestyle. Some have actually gone on, and this is not, I shouldn't say some have gone on to say, there's actually research published which has informed us that sitting is the next smoking. So if you are primarily spending your day sitting on a chair or sitting in front of a computer, or and this, by the way, goes true for all ethnicities, all races, across the spectrum globally. These are global cardiovascular risk factors. And then certainly unhealthy diet, and the one factor which is enumerated here, which I missed, is coming into prominence now, and that's, we call it LP little a, or lipoprotein little a. And if the levels of lipoprotein little a, LP little a, are elevated, it's a marker of heightened risk for heart disease. And I think if anyone who's listening who sees a primary care doctor or sees a cardiologist, this specific marker is not reported in your lipid profiles. If you are going in for your preventive checkups, and if you're getting blood draws, and if the doctor is coming back to you with results of your cholesterol panel, LP little a or lipoprotein A will not be resulted, because it's not something traditional lipid panels measure. So if you are really interested in knowing about your elevated risk, you'll have to request your doctor to see if they can also order LP little a levels, and sort of discuss the results with you. You certainly, it's an evolving area of the literature, and many providers may not be comfortable or aware of this being another marker which sort of defines risk. And if that is the scenario, then certainly reach out to a few of us who are well aware of the advancements in the field when it comes to particularly this specific risk marker. All right, next slide. So this is the recently released Life's Essential 8, and I think it used to be popularly called or known as Life's Essential Seven. And I think American Heart Association went a step ahead and included the eighth parameter here, which is sleep. So getting getting at least 8 hours of sleep is important. And I sort of smile and chuckle when I say that to the audience, because I'm guilty of not getting full 8 hours of sleep myself. So I try to do my best to get at least at least 6 hours, if not more, of sleep. But I think some of the other things, I'm sure you've heard even in lay press or popular media, eating a heart healthy diet, and we will discuss more about what a heart healthy diet looks like. Being more active, certainly smoking, quit smoking, or don't even start smoking, don't even light up a cigarette. I already discussed sleep, managing your weight, controlling cholesterol, managing blood sugar, and managing blood pressure. I'm sure that by now in 2024, all of us have repeatedly heard about these Life's Essential Seven or Life's Essential Eight. And what I'm gonna do for the remainder of the talk is sort of try to sort of make it easy for the audience to sort of get these boxes checked, because I know that it can become very hard to sort of be aware or be mindful of how to get these things in check. All right, next slide. Okay, so let's talk about diabetes mellitus here, which essentially is in our world as cardiologists, it's sort of we call it the risk equivalent. What does that mean? It means that if someone is diabetic and comes to see us in our clinic, we sort of assume that that patient has underlying heart disease because it's as bad as having heart disease. So diabetes, particularly in the South Asian population, is as bad as having heart disease. And you can see in the numbers in that blue box that the prevalence of diabetes in South Asians, once again, is higher compared with other races and other ethnicities. And I think a lot of people have asked as to why that is the scenario. I call it epigenetics, so that's epidemiology and genetics. So not everything can be just blamed on genetics. It's also how we live our lives. And I'm talking culturally of particularly South Asians. I'm of the same culture, so I'm very familiar with how we live our lives. Most of our lives are sedentary. Sports is not inherently a part of the culture. Growing up as South Asians, I mean, yes, the most popular sport in India, for example, or even in Pakistan, Sri Lanka, I would venture out to say, even Nepal, is cricket. Um, and while we really enjoy, watching cricket, unfortunately, um, as lay public, very few sort of delve into sport. I think culturally the focus is always, in seeking more knowledge and more education and getting into competitive fields like healthcare. I mean, like I discussed in my slide a few slides ago. And so inherently as a culture, South Asians are not outdoorsy, not physically active sort of communities. And then, so that's your sedentary lifestyle. Now, add on to that the way our diets, the way we consume food is different. I mean, protein is barely existential in South Asian diets. The closest source of protein that we eat routinely in South Asian households are lentils. And if you look at lentils, even lentils are a rich source of carbohydrates. Certainly they have protein, but they're a rich source of carbohydrates as well. And also, how we pair our lentils is important. So we will pair them with white rice and we'll pair them with bread, and that as an additive source of carbohydrates. So if that is your major meal, if that is your major staple meal at dinner, you see that the source of protein is abysmally low, and that promotes glucose intolerance, and that promotes impaired fasting glucose. It sort of heightens the risk of us getting diabetes downstream. And so you sort of see how your lifestyle compared with what you eat is already putting you at a heightened risk. And then the third big factor is, our our affiliation or our sort of predilection for eating food which is fried. I mean, I think the kinds of foods that we consume with one of the most popular drinks in our households, which is tea, black tea or chai. I'm sure everybody knows what chai is. Then we sort of try to pair chai with fried food like fritters, like vegetable fritters. Now, granted, most of our food is vegetarian, and if you listen to the Western media, particularly vegetarianism or veganism or vegetarian diets are healthy, but it's also how you're cooking your food, which is important and which matters. So if you are eating vegetarian food, but it's all fried, deeply fried food, then that is not healthy, and it's going to put you at an increased risk for heart disease. All right, next slide, please. I think I've sort of stressed upon some of these factors already. I've talked about diet. I've talked about physical activity, and I think a good number, if some of us are focused on research, then masala, which is basically uh, the the study of atherosclerosis in Asians. It's a study which was pioneered by a physician, clinician, investigator. Her name is Alka Kanaya. You can look her up. She's we've worked closely together. She's fabulous researcher. She's based out of San Francisco in California. She is a professor of medicine at University of California, San Francisco. And her, along with Namrata Kandula, who is based out of Northwestern, so not in Chicago, so not far from us, have pioneered masala, which is basically studying South Asians longitudinally from different cities within the US. But the studies which they initially, the patients or the subjects which they initially enrolled were in the cities of Chicago and San Francisco. And what they've shown in their several of their papers now is that our physical activity in South Asian cohort is almost 30 to 50% less if you compare it with other groups. So if someone wants to put a number as to how much less are we physically active compared with some of the other ethnicities and cultures, it's 30%, almost by 30% to 50%. That is startling. And then our BMI tends to be lower. This is again looking at the South Asian population. And I don't know how many of our audiences are familiar with Hindi or Urdu, which is the most common language that is spoken in our households. But in that particular language, and I'm not trying to sort of generate stigma here, because I know how this can be stigmatizing or sort of polarizing. But there is a word in Hindi which is called mota, which what that means is literally means fat. Not fat in diet, but fat in the sort of in the visual sense or in the physical sense. But what that stands for in South Asians is metabolically obese thin adults. So M is metabolically, O is obese, T is thin, and A is adults. So it's an eponym, it's a mnemonic, or it's a moniker which sort of brings the message home that even though we may be thin looking, we may be thin appearing in our physical appearance, we carry a lot of quote unquote thin fat in our bodies as to how we're composed. And that is a combination of factors again. I think our overall muscle mass, if you compare it with Caucasians, for example, is low. That again goes back to how we consume our food, our diets, and also the level of physical activity. We tend to store more visceral fat and ectopic fat compared with other cultures and ethnicities, and that is a nidus for us to be predisposed to diabetes, for example. And we have our culture has a lot of central obesity. So again, that is pointing toward visceral fat. All right, next slide, please. So I've sort of talked about this. I think some may argue that body mass index, which is one of the most popularly measured uh, parameter of weight and how your weight is in comparison with your body height, then some would venture out to say that that's really not a good parameter. And I kind of agree, because it is not taking into account the muscle mass. So someone can be extremely muscular and by virtue of being extremely muscular, have a higher weight and have a higher body mass index, compared with someone who is, not as muscular, may have a lower body mass index, but may still be metabolically more vulnerable to, say, for example, diabetes. But what the importance of this slide here is that, again, if you compare South Asians with whites, our predisposition to having cardiometabolic abnormalities — what do I mean by cardiometabolic abnormalities? I mean diabetes, I mean high cholesterol, I mean high triglyceride levels. And when I say high cholesterol, that's high bad cholesterol levels. So for South Asians, even at lower body mass indices compared with whites, we start to get more cardiometabolically unhealthy, particularly compared with whites. All right, next slide, please. So this, gets me to body composition. Again, something all of us are very familiar with, and these are, numbers which again are based from predominantly Caucasian, population, so Caucasian research. And like I explained to you in my last slide, for South Asians in particular, even lower body mass indices, for example, say 21 or 22, compares with 24 or 25 for a Caucasian. But I'm sure all of us are sort of familiar. I'm assuming that all of us may be familiar with this. How do you get your body mass index? Is you are basically the numerator. So the equation is that the numerator is your weight in kilograms, and the denominator is your height in meters. And you sort of impute that into a calculator, and out comes the body mass index. And I know that a lot of lay people sort of try to measure it all the time. If they're trying to measure it all the time. Again, I'm not saying that it's not accurate. It is, but it may not be the best parameter out there to sort of gauge your health. All right, next slide, please. Okay, next slide. I've dialed this down, even before in my talk previously. All right, next slide. All right, so coming to high cholesterol levels. So, there is a higher risk for heart disease if, certain cholesterol um, parameters are high or low. And what do I mean by that? So if you go to a doctor and if you get a cholesterol panel or a lipid panel, what you get back is your total cholesterol levels. You get your bad cholesterol, which is LDL. You get your good cholesterol, which is HDL, and you get your triglycerides. Now, in South Asians, there is a phenomenon, or even in diabetics, there is a phenomenon called mixed atherogenic dyslipidemia. What do I mean by that? That's sort of a medical jargon, so I'm going to try and explain that to you. What that means is that your bad cholesterol is high, so your LDL is high, your triglycerides are high, and your good cholesterol is low. Now, we've seen that, or research has shown that, particularly in South Asians, that pattern is highly prevalent, regardless of diabetes status. So when you are getting your lipid panels, you specifically ask your doctor about good cholesterol levels, about bad cholesterol levels, about total cholesterol levels, about triglycerides. Sometimes, these numbers are within the ranges, but still it's important to key in into each of these numbers, because an individual number means something when it specifically comes to heightened risk of heart disease in the future. All right, next slide. I've talked about this earlier. This is sort of the new kid on the block, for lack of a better word. So there's research now, again, published in some of the leading journals in heart disease and in medicine, which have shown that this new marker called LP little a, or lipoprotein little a, is associated with disease not only in the heart but even in other vascular beds. What do I mean by that? So when I say other vascular beds, then I'm talking about arteries in the legs, I'm talking about arteries in the neck, talking about arteries in the brain. So stroke, peripheral arterial disease or PAD, certainly heart disease. So again, if you're interested to know about your cardiovascular risk, so not only heart but also vascular risk, again, this new kid on the block may be something you need to start having conversations about with your doctor. All right, next slide. And this once again is sort of medically busy slide, but again, if you read the box which is colored green, it will tell you that in most people, LDL, which is the bad cholesterol, is much more abundant than this new kid on the block, which is LP little a. But read the last sentence there, that on a per particle basis, this new kid on the block, LP little a, is about 6 times more potent in causing the disease compared with the bad cholesterol, which is LDL. So I think that if you want to take one thing away from this talk when it comes to cholesterol levels and this new kid on the block and a new marker for heightened risk of heart disease, talk to your doctor about getting LP little a measured in blood work, because that is going to give you additional information about your risk of heart disease or even other vascular events in the future. All right, next slide, please. All right, so this is again going back to our world map. This is sort of how we started our talk. And then you'll see that the estimated world population with elevated LP little a levels, and the threshold that we go by is typically 50. It's measured in milligrams per deciliter. That number is not a trivial number. It's 1.43 billion globally. So that's a lot of quote unquote healthy patients. Now these are healthy patients. You'll see the dichotomy based on gender, so men versus women in different regions. For example, in the US, the prevalence is about 20% compared with, say, for example, in Africa or in India, where it's 30% or 25%. And then you'll see that in absolute numbers, what those boxes are telling you is that how many are men, in millions. So, for example, in North America, you have 73 million men with elevated LP little a levels, compared with Africa, where it's 376 million, or 469 million in India. So these are sort of some of the numbers which again, epidemiological population health studies have shown. All right, next slide. All right, coming over to tobacco, and what is the trend in Asians in the US, specifically Asians. I'm not talking about other ethnicities. If you want to look at sort of other races or ethnicities, you'll sort of look at the histogram on the right side. So smoking, the prevalence of smoking in Asians in the US is 7.3%. You compare that with American Indians or Alaskan Natives, it's 26.4%. Smoking in whites is about 15%. And other racial ethnicities is about 22%. So I think, again, not a small number, but I think if you compare it with other ethnicities and cultures, as a culture, we tend to smoke less, which again is the number in absolute terms is still pretty high. But if you compare it with other cultures, the prevalence of smoking is low. I think overall these numbers are pretty abysmal. If you want to see, sort of talking as a cardiologist and ubiquitously looking at all the cultures, these numbers are still very, very high. And we know that there's nothing good that comes out of smoking. Not a single health benefit of smoking, if you will. And has associations with many disease states. Has associations with cancer, with heart disease, with atherosclerosis, with vascular disease. So not a good idea. So if someone who's listening, who's smoking, I think if I can impress upon you, or if I can inspire you to not light up another cigarette, I would have done my job in this talk. All right, next slide, please. So this sort of breaks it down even further. So within Asians, you'll see that I think as a culture, maybe Vietnamese and Korean populations smoke more compared with, for example, Chinese and Asian Indians. And you sort of have the Filipinos and the Japanese in the middle in that table. All right, next slide. So I'm sort of this is sort of a provocative slide, and what I'm showing here is a scene from one of the movies in our language, which is Hindi cinema or Hindi movie. And this gentleman here, I don't know how many of you know him, but if you don't know him, he's one of the most popular actors in our industry, and he's sort of very famous for his physique, as you can see, and it's sort of an oxymoron that this gentleman is sort of lighting a cigarette. So on one hand, has this physique that he wants to portray and sort of portray himself as a signature of health, and on the other hand is lighting up a cigarette. So this is not cool by any stretch. Is not cool. And I think on the left hand side, what this slide is showing us is some of the other forms tobacco is consumed in our culture. So it's not only smoking, because filtered cigarettes actually um, tend to be costly, if you were to look at how costly they are in India. So there are companies which have manufactured other forms of tobacco which can be put into these, I call them cigarette phenotypes, called beauties. Or I mean, we certainly have hookah parlors even in the West now, but hookah traditionally was a famous form of smoking, if you want to go back to medieval Indian times. And then chewable tobacco certainly is very, very popular. It's super popular in India and super popular in our cultures, unfortunately. So um, I think tobacco consumption in any way, shape, or form is harmful, is not safe, and sort of portends poor prognosis, and puts you at a heightened risk of heart disease and other disease states as well. I mean, I think one of the most common causes actually of cancer in the mouth, or what we call as oral cancer in India, is chewable tobacco, because that irritates the mucosa, causes changing in the lining of the cells in the mucosa, and sort of puts the populations at an increased risk of not only heart disease but also cancer, oral cancer. All right, next slide, please. So getting to what is important, and I know that we're approaching the hour here, so Jennifer, feel free to interject when I need to stop. But I'm gonna sort of go to this notion of how do we eat a heart healthy diet. So what do I tell my patients? And the rapidity with which I'll say the sentence, you'll probably realize how much I say the sentence in clinic to my patients. So, what is a heart healthy diet? A diet which is rich in fruits, vegetables, whole grains, legumes, nuts, olive oil, tea, coffee, water is your best beverage. That's what I say. So, when I say that, I typically take a breather, patients take a breather, and then I explain to them what do I exactly mean by eating a diet which is rich in fruits and vegetables and whole grains and nuts and legumes and extra virgin olive oil and tea and coffee and water. So what I tell them is that if in any meal, be it breakfast, be it lunch, be it dinner, if you can count at least 5 colors, if you can count at least 5 colors, you've done a good job in composing your plate, which may be considered heart healthy. If you are not seeing 5 colors, you need to do a better job in composing your meal plate. And I sort of is the mantra that I go by when I'm consuming food. So leafy greens. The American Heart Association recommends at least 4 to 5 servings. Fruits at least 2 to 3 servings. Uh, you know, Try to avoid red meat. As much as you can. I know that sort of I always get the eye or the eyebrows lift when I'm saying that to patients in Indiana. Poultry and fish in moderation. So fatty fish, where salmon is very good, very heart healthy. Maybe 1 to 2 fatty fish meal per week. Poultry in moderation, dairy in moderation. Focus on eating fruits and leafy greens, um, and whole grains which are not processed. The other important aspect here is, being as close to the source as you can. So the more processed it is, the more um, the ingredients you have to read on a label, the less heart healthy that meal or that product is. And the easier it is for you to read the ingredients on the food label, the easier it is for you to procure the food from the source, meaning from where it was grown, the more healthy it is. And so try and tailor your diet in such a fashion so that you can be mindful of these things when you are consuming or putting anything in your mouth. All right, next slide, please. Okay, so this is, again, I put this slide here on purpose. I don't know if how many of us are we're tuned in who are, South Asians, or how many of us, love Indian food. I certainly love Indian food, but I try to avoid all these meals that I've sort of put on the slide deck here. I mean, this is sort of a typical menu. You go to any popular Indian restaurant, you get these very delicious curried lentils or curried chicken. There is this basmati rice, which is very rich in starch, and you get the naan bread. Our starters, again, very delicious, very all vegetarian, right? Vegetarian items, very supposedly quote unquote healthy, but they're deeply fried. So these fritters or these samosas or these vegetable fritters are deeply fried, and again it sort of takes the healthy of the vegetarianism is sort of gone when these products or these items are deep fried. And then our desserts, which are as delicious as they are not the most heart healthy food items we can consume. So these dumplings, which are again just loaded with sugar, are deeply fried. Or even these sweet fritters on the bottom right, which we call them jalebi, and it's sort of paired with a dairy product called rabri, are super super delicious, but again not the healthiest food you'll eat, unfortunately. So again, limit, if few of us in the audience love going to Indian restaurants, probably limit that visit to maybe once every 2 months, I would say, or give yourself that cheat day. And again, whenever you're consuming food at a restaurant, be mindful of your portion sizes. I think that's extremely important. I think everything in moderation goes a long way. All right, next slide. So coupled with that, so not only is our food unhealthy from a cooking perspective, now we have grown our palate to Western diets. So refined flour or heavy cream, and certainly these deep dish pizzas, which, I mean, we're close to Chicago here, so I know what I'm talking about. And then increased consumption of red meat. None of this is healthy either. So I mean, it's not a surprise that even in the US, heart disease is the number one killer, because unfortunately all the cultures have sort of found themselves consuming foods which are rich in fats and rich in saturated fats, unfortunately, and rich in added sugar. And that is a potent combination for increased risk for heart disease. Next slide. And Jennifer, it's at the hour, so I mean, if you want me to stop, I'm happy to stop, and if you want me to take questions, I'm happy to take questions, because I know we're getting toward the end of the talk anyways.
Right. How about 5 more minutes to
Okay.
talk? We
Okay,
got a
perfect.
late start.
Yeah, perfect. Not a problem. So this is, again, my stroll through an Indian grocery store. As you can see, these are some of the food items we tend to consume as quote unquote snacks, or these are our snack items, which popularly in our culture we pair with chai. And you'll see that each of these items, which again have a lot of vegetable oil, which is hydrogenated, rich source of saturated fat, not good, not good for heart health at all. So again, I try to move away from this aisle. Don't even look at it if you can. I try not to even look at it, but I know I may be the only one in my family, because I happen to be a cardiologist that does not look at it. Everyone else, I mean, that's sort of the most popular section in the Indian grocery store, where all the family members are sort of focused on. All right, next slide, please. Optimizing diet and lifestyle to reduce risk for heart disease in South Asians. I've sort of talked about this, at length, and this is one of the papers if anyone is interested. Um, the final author here is Anandita. She's a good friend of mine. She's a cardiologist. She's based out of Dallas. Is running a similar study to masala called Dilwale, which is again a very popular Hindi word, and in the vernacular means that it means populations with big hearts, which again is a cute name. And what she's trying to do is she's trying to establish a cohort of South Asians, again Texas and Dallas being a state with rich population of South Asians, and trying to study us and disease patterns in us long term. And so she's published some seminal work. As a matter of fact, the slide deck is something that she put together for this talk, and I'm grateful for her that she did that. So we work together. We work closely together. She's part of the steering committee for my nonprofit, and I'm gonna sort of get into that maybe toward the end of the talk if you have some time left. All right, next slide, please. So eat this, not that. Again, if you want a copy of this, I'm happy to share a copy. I mean, this is meant to be as a guide for all of us who are tuned in and listening. And this is particularly enumerates some of the commonly eaten foods in our culture, which we've tried to come up with an alternate list of food items which we should consume in comparison with some of these items which are very popular in our diet. So, Jennifer, if someone asks for this, feel free to share. All right, next slide. And so again, I mean, I think I've sort of honed in on this, right? So closer to the source when it comes to whole grains, that's your bottom left. Fruits and vegetables are your top right and top right and top left. Again, our culture tends to focus a lot on dairy products. Consume them in moderation. Try and not have whole milk every day. Maybe once a week is fine. I know lassi is very, very popular drink in Indian restaurants. If it's strained yogurt, and if it's primarily salted, I think that's a healthy drink. If it's sweetened, again, is sweetened, or particularly mango lassi is super popular, is not a healthy drink at all. As tasty as it is, my boys love mango lassi. It actually is not a healthy drink. So again, if you're having it maybe once a month or maybe twice a month, that's fine. But having it on a daily basis, not healthy. And then on your bottom right is your some of the vegetarian sources of protein. So whether it's lentil, whether it's tofu, or the Indian cheese, which is paneer, again, if you can do maybe 50% of fruits and vegetables and 25% of whole grains and 25% of the rest, I think that's a good sort of distribution for our Indian plates. All right, next slide, please. So again, sort of the idea of putting this is to hone in on this question, as to start thinking about what you're ordering, which is heart healthy, and you'll be surprised how much is not heart healthy at an Indian restaurant. All right, next slide. I'm gonna go to the last slide here, Jennifer, and then we're gonna stop and take questions. I just want to spend a few minutes talking about the initiatives through my nonprofit, particularly CHAI, which is Cardiovascular Health in Asian Indians, and talk about some of the work we've done.
Okay. Yeah, Kirsten will get us there.
Yeah, thank you. So again, a lot of material here to share, but I'm going to end this talk with just mentioning briefly about what we're trying to do in the state of Indiana through my nonprofit, which is makeadent.org. CHAI is a cohort which has been is a steering committee and a sort of an awareness program which has been established by the nonprofit. It's the moniker or the eponym stands for Cardiovascular Health in Asian Indians. We've got an esteemed steering committee. These are all my colleagues. All of them are cardiologists. Dr. Kulkarni, Anandita Kulkarni, she's the one who I've mentioned about even earlier, is based out of Dallas. Dr. Patel is at Johns Hopkins. He's in Baltimore. Dr. Nasser is at Houston Methodist in Houston. Dr. Natrajan is a physician investigator at Mass General and Harvard Medical School in Boston. And you have Dr. Budoff, who's a professor of medicine and a preventive cardiologist at UCLA. So you'll see, I mean, pretty much, the coasts and major institutions and organizations reflected. And, across the spectrum of all these fine investigators, you have a significant component of literature which has been developed around South Asian heart health. And Pradeep from Boston has come up with a National Institutes of Health, so NIH-funded study called Our Health Study, where he's actually collecting salivary samples. So if you can give his team a sample of yours, then he'll do the genetic testing and the analysis, and they're assembling a cohort together to better understand some of the genetic markers of disease. And I'm sort of involved in a similar cohort with Dr. Nasir. Um, and we're trying to do similar work ourselves through CHAI, or have been at least for the past 6 months. So if you want to delve more into this topic, or have more questions, or want more awareness, or want more educational materials, feel free to reach out to me or any of these people, or even makeadent.org, and we'll be happy to help you. But I do think it's important that we start realizing the crucial importance our culture plays in heightening our risk of developing heart disease. And I think the sooner we can start by imbibing some of these preventive aspects that I shared with all of you, I think the better we will be, the better our families will be, and we can curb this menace, because it indeed is a menace. And with that, I'll stop. Thank you for your time, and thank you for listening. And I apologize for a delayed start.
Well, thank you, Dr. Kalra, for a very interesting presentation and a lot of good information. And thank you to our participants for attending. You've all taken an important step toward improving your heart health just by increasing your health literacy. As Dr. Kalra mentioned, we will share an email with a link to this session, and we encourage you to share it with family members, and maybe to take a look at it again and look at some of the slides that Dr. Kalra has put together with some good information, especially about his suggestions for a healthier diet across the board. I have just a couple of comments in the Q&A. One of them, here's one. Could you say a little bit more about exercise? Maybe about how to get started, or what you recommend to patients, like I say, in getting started, or how to decide what will work for them.
Yes. So, exercise, I think it's an important aspect of my discussion with the patients. I would say any activity is better than no activity at all. The American Heart Association recommends 150 minutes per week. That's 30 minutes in 5 working days. So I think if you can engage in moderate intensity physical exercise, whether that's biking, hiking, jogging, running, walking, even walking. I mean, I think if you can accomplish 10,000 steps, then that's a great start. So start measuring your activity. It actually has become very easy with smartphones and Fitbits or what have you. It's just become very accessible to document how much physically active you are. So I would start with any physical activity. I think for those of us who have sitting jobs or jobs in front of a computer screen, I recommend getting adjustable tables with adjustable heights so that you can stand sometime, because standing is much better than just sitting. Then you also have these fancy treadmills which you can actually put underneath your desk. So even when you're sitting, you can just like move your feet while you're sitting and working on a computer. That way, you're getting some form of movement in, because movement is crucial. Regardless of the intensity of the movement, any movement for a job that involves a lot of sitting is crucial. But I would start off with, just hike maybe 30 minutes. 30 minutes is not even, people usually come up with the alibi of not having enough time. And, I tell them, look, 30 minutes is not even 2% of your 24 hours. It's not even 2%. So if you can't even devote 2% of your daily time to yourself, I mean, that is sort of an unfortunate statistic. And usually that opens people's eyes. It's like, oh, wow, it's just 2%. Like 30 minutes is literally just 2% of the entire day. I think all of us can devote 2% to our health, by physical activity, or by just walking, hiking, jogging, running, cycling, biking. I think also, participating in community events, building a community around, or like socializing around exercise, I think is another sort of enhancer, for lack of a better word, for our abilities to pick ourselves up and go for an exercise, go for exercise. um, I think the best form of exercise, if you were to ask me, like, what is the best form of exercise which is shown to have the greatest health benefit, I would say it's a combination of resistance training, which is training with weights, and high intensity interval training. So if you can involve or indulge yourself in a concentrated 20 to 30 minute program with weights, so that involves resistance training at high tempo, that's high intensity interval training, that has been shown to have the maximum benefits. Because when you lift weights, so when you're lifting weights, you are increasing, that has a great benefit on bone health. It actually replenishes your bone formation a lot quicker. You are building muscle mass. When you're building muscle mass, you're decreasing insulin resistance. When you're decreasing insulin resistance, you're decreasing your bad cholesterol levels. When you're decreasing your bad cholesterol levels, you are decreasing atherosclerosis and plaque formation in the arteries all over the body. So, and what the other good thing about exercise is that it forces the intake of insulin by muscles, because insulin is a hormone which our pancreas produce naturally. We all need insulin. And it's when our pancreas are tired of producing insulin because of how frequently we eat and how we eat, is we start developing insulin resistance. Well, what exercise does is it actually promotes the intake of insulin by muscles a lot more efficiently. So it decreases insulin resistance. So exercise has a lot of benefits. I mean, it certainly, and I haven't even started enumerating the mental benefits, like the mental health benefits of exercise. Just the physiological and physical benefits of exercise are, you're going to increase your bone health, you're going to prevent osteoporosis, you're going to prevent hip fractures, which are the leading causes of death in the elderly. You're going to increase your muscle mass, you're going to decrease insulin resistance, you're going to increase your good cholesterol without any diet supplements. You're going to decrease bad cholesterol, and you're going to improve your overall heart health. So I can't tell you how much exercise is crucial, vital. It's sort of like the secret elixir of youth, and could be, like I said, any aerobic activity. If you want to start off with, maybe light walks, jogs, runs. Even like if someone is having a sitting job, like just standing up from your chair and doing like 10, 15, 20 squats, then sitting back down, even that is beneficial. Calisthenics is a great form of exercise. You're using your own body weight. So if some people are like, I don't want to use weights, it's too much for them. Use your own body weight to exercise. I think if you can lift your own body weight and sort of do squats and do push-ups and do planks, that alone is going to start building and replenishing bone, as well as start building muscle. I hope that was helpful.
Oh, no, I think it was. In fact, it was a follow-up question. A recommended target activity level to aim for, but I think you outlined that anything that's going to help build muscle mass, as it, then weights, can do that, and to build, bone density. And yeah, so that, yeah, I think you answered that other follow-up question as well. Um, yeah, that is great. That's what I know. I'm working on myself to decrease the fat and increase the muscle mass. And I know that's going to help me in the long run.
Yes, and I think all of us have aspired to do that, and I think the one thing which has helped me, Jennifer, is that I've started logging. That was one of my sort of resolutions. So on my calendar, I'm at day 207 of logging food for straight consecutive days. And it takes at least 10 days to sort of build a new habit. So don't give up on yourself, and keep doing it. And then it just becomes part of who you are. But food logging will help you lose fat and will also sort of make you aware of what are the constituents of your diet
Right.
in terms of carbohydrate, fat, protein. And just being aware of that fact is going to make you lose weight, is going to help you increase protein, is going to help you decrease carbohydrates and fats in your diet. And if you pair that with exercise, that is going to make you increase muscle. And what I tell myself and what I tell patients is the following. It's very easy. You gain muscle in the gym, you lose fat in the kitchen. So you cannot outrun a bad diet. You cannot work out for an hour and then eat whatever you want. That's not going to work. It's never going to work. You
Hmm.
have to be mindful of what you're eating. So you gain muscle in the gym, you lose fat in the kitchen. You never lose fat by working out or by running or by
Right.
jogging. And I think that is a very popular misconception amongst the lay public, that I can eat whatever I want as long as I'm expending my energy, as long as I'm working out, I'll be fine. No, you'll not be fine. You lose fat in the kitchen. No matter what you do, you lose fat in the kitchen, you gain muscle in the gym. And if you can sort of remind yourself about this simple fact every day, that's going to go a long way in
Mhm.
making sure that you're eating healthy and you're exercising properly.
Yes. Well, thank you very much again, Dr. Kalra. This has been a really good discussion, and you've given us a lot of additional topics that I think will make great future webinars as well.
Oh,
Um,
yeah. Thank you. Thanks
yes,
for having me.
and thank you everyone for participating. And you will be receiving a survey of our event. And please give us your feedback and any other ideas you have for future webinars. And Kirsten, I think can we call it a night now? Thank you so much.
Thank you.